Alright, in this discussion we'll be taking a look at the various heart valves and also talk a little bit about coronary circulation. Excuse me. In this image you can obviously see all four heart valves. In this position they're all closed. And it makes it a little bit easier to kind of compare and contrast some of the structure of the valves. At the bottom here you have the two AV valves that we mentioned before. You can see the bicuspid valve with one and also two cusps here. And then you can also see the tricuspid valve here with 1, 2, and 3 cusps. In the upper positions here you can see the two semilunar valves. Here you have the pulmonary valve and below it the aortic valve. Notice that both the pulmonary and aortic valves both have 1, 2, and 3 cusps respectively. And they're very similarly structured. In fact, if you obviously observe these two valves independently of each other without their relative positions, you probably wouldn't be able to tell them apart. Now the valves are held in place by various components of the fibrous skeleton of your heart. So you can see some of those components here. You don't have to note any of those, but these are the various structures that help anchor the various valves in place. Now you do need to know in general what those valves are going to do and what their function is, and I mentioned that to you before. The valves are here to prevent backflow, prevent blood from moving in the wrong direction. Or we could say that in the opposite way by saying simply that the valves ensure one-way flow of blood through the heart. So either way, technically speaking, is acceptable. Now keep in mind that the atrioventricular valves, the AV valves, the tri and also the bicuspid valve are there to prevent backflow of blood from the ventricle into the atria, and then that the semilunar valves are there to prevent backflow of blood from the exit vessels, the pulmonary trunk or the aorta, back into the ventricle. So once again, ensuring one-way flow or preventing backflow, that is the major job here of all the valves. Now when we start to talk about how these valves work, there's one key buzz phrase or catchphrase that you definitely have to keep in mind. And that key buzz phrase or catchphrase is going to be pressure changes. All the valves work in response to pressure changes. Now when your heart works, certain chambers contract and certain chambers relax. And when a chamber contracts, the pressure goes up. When a chamber relaxes, the pressure goes down. And these pressure changes are going to cause blood to move. And blood always obeys the laws of physics, and it must move from areas of higher to lower pressure. So let's take a look at this area here from the image and talk about how the AV valves are going to work. Let's just say that we have a scenario where the left ventricle here, its walls are relaxed. And then we allow the left atrial walls to begin to contract. As the left atrium will contract, the pressure will go up. The relaxation of the walls of the left ventricle will cause its pressure to go lower, and at some point the pressure in the atrium would be higher than the pressure in the ventricle, and blood would move from high pressure to low pressure, and the AV valve would swing open, and blood would begin to go from high to low and enter the ventricle. And that's what you're seeing over here on the left hand side. A higher pressure in the atria above, lower pressure in the ventricle below will force the AV valve open, allowing blood to move from atria and into ventricle. Now at some point the ventricles will begin to contract while the atria relax. As the ventricle contracts, its pressure would climb higher. As the atria relaxes, its pressure would fall lower. And at some point the pressure in the ventricle would be greater than the pressure in the atrium. In other words, blood would now have a reverse situation. The higher pressure being in the ventricle will cause blood to try to move upward into the atria. That is not the correct direction. So as blood begins to rush up, blood will fill the cusp of the AV valve, in this case the bicuspid valve, and those cusps, as they fill with blood, would eventually come together, something like a parachute filling with air. Once those cusps are united together, they close off the opening and therefore would prevent blood from moving back into the atrium. Now these cusps have to be anchored to your ventricles, otherwise those flaps, the cusp, would basically just be blown or forced open in the direction of the atria. So to keep them from reopening once they come together, enter now your chordae tendineae and also the papillary muscles that we talked about during our anatomy discussion. The chordae tendineae, along with the papillary muscles, anchor those AV valves in place. So once the cusps come together, the cusps no longer will continue to move due to the contraction of the papillary muscles and the pulling action of the chordae tendineae. So that is how the AV valves work. Essentially, once again, it's all about pressure changes. Now when we look at the semilunar valves and how they work, one moment here. I don't really have an image that goes through it, but it's a similar process essentially. I'm going to use the image that we took a look at here. Notice the semilunar valves, their cusps are shaped kind of like cups almost. So what happens is, at some point there's a tendency, due to the relaxation of the ventricle's walls, for blood to attempt to be sucked back into the ventricle. As blood begins to rush back toward the ventricle, these cusps fill up like cups being filled with fluid or beverages. And as those cusps fill, they will expand and eventually come together, and the cusp of the semilunar valves will close off the ability of the blood to re-enter the ventricle. So it's still pressure changes. Blood always will move from high to low pressure. It's just that when that pressure changes and the pressure dictates that blood should move from high to low in a direction that we don't want it to move in, well then these valves will close off, and that should prevent blood from moving in the wrong direction, even though the pressures dictate that that's the direction blood should flow in. Now, I want to say a few words here about coronary circulation. There's not a tremendous amount of information that I'm going to hold you responsible for from it. But here you can see the various arteries that help supply blood to the heart. What I usually tell people is that the heart is greedy. It's greedy because it will take care of itself first before it takes care of anything else. So the exit point for oxygenated blood from the heart was the aorta. And the first vessels that arise off the aorta are going to be the left and also the right coronary arteries. These are going to be the main supply for oxygenated blood to the heart. The heart is a muscle. It has to produce ATP in order to keep working correctly. And in order to do that, it needs a tremendous amount of oxygen to do so. Now, I do want you to be familiar with one of the branches off of the left coronary artery. It's called the anterior interventricular branch. It runs in the anterior interventricular sulcus. The job of this vessel is to supply most of the oxygenated blood for your ventricles. Very important, because the ventricles are the workhorse of the heart. They're the chambers that do the most work, so consequently the vessel that supplies most of the oxygenated blood to those ventricles obviously is going to be important as well. When it comes to the veins, the major vein that I want you to be familiar with, we've already mentioned, the coronary sinus. That is the vein that drains the majority of the heart of deoxygenated blood. So, I want you to know those few vessels, not a whole lot. You can see there's many others. If you get a chance, you can look through them in your book, but those are the ones that you absolutely, definitely have to know. Now, to kind of wrap up this discussion very quickly here, I want to talk to you about two clinical disorders and tell you some highlights of each and some things that you'll need to know for the purposes of your test. Those two disorders are called Myocardial Ischemia, ISCHEMIA, and also a Myocardial Infarction. A myocardial ischemia is what we technically define as a hypoxic event. Hypoxia is a situation in which there's a decreased flow of oxygen to cardiac muscle. The hypoxia leads ultimately to the fact that the cardiac muscle switches over and begins to carry out anaerobic respiration. The anaerobic respiration leads to a buildup of lactic acid, and that lactic acid can usually become possibly at least damaging to cardiac muscle. Now, usually as the acid levels build up, the muscle begins to be slightly, potentially at least, harmed. It usually promotes pain, and this pain is called angina pectoris. And the angina is usually kind of the shorthand way of saying it, but angina pectoris is usually associated with myocardial ischemia as a result of the hypoxia that the heart incurs. Now, key thing here to keep in mind, myocardial ischemia is a temporary condition. Usually, you do get the chest pain, but long term, there is not going to be any permanent damage to heart muscle. However, we can contrast that with myocardial infarction. A myocardial infarction is a situation in which there is significant damage to that heart muscle, usually as a result of what we call an anoxic event. Anoxia means no oxygen reaching the muscle. Now, usually that situation arises as a result of something that blocks one of those major coronary vessels, like an embolus or some type of thrombosis. That's why I mentioned the anterior interventricular branch to you earlier. A lot of times, if that branch becomes significantly blocked, then you are going to run the possibility of developing or having a myocardial infarction. And by the way, a myocardial infarction is commonly referred to as a heart attack. one of the key differences that differentiates a myocardial infarction from a myocardial ischemia is the damage. Like I told you a minute or two ago, with an ischemia, the damage isn't permanent. But with a myocardial infarction, there is long-term significant damage if that person survives. So that person will lose some heart muscle as a result of an infarct, versus an ischemic event where you'll have some pain usually, but you don't usually suffer long-term damage. So I want you to know what's behind a myocardial infarction or ischemic event, and you should also understand the consequences. One has permanent damage, whereas one does not.